My name is Wellington Santos. I am a trauma surgeon and I'm representing a public trauma, level 1 trauma surgery hospital base in Brasilia. And our society, our trauma society, but it's a pleasure for us to represent Brazil in this Tele-Grand round in Panamerican Society. Thanks for Dr. Marcos for the invitation opportunity now, okay? Just a few, yes. First of all, I will show our resources to facilitate the conduct of this case. We have in our emergency department ultrasound, blood bank, laboratory, machine of blood gas analysis, X-ray, and we have a CT angiography that can perform 20 hours a day. We have an operator room that can stay in the second floor, but the access was very fast. This is our emergency room where we have here ultrasound, we have a defibrillator, we have a mechanical ventilator, and we have capacity to make a surgery if necessary, okay? And we don't have a massive protocol, transfusion protocol in our service, but our blood bank is very fast when you ask them blood products, okay? Let's go to the case now. He's a male, 29 years old. He was admitted in the emergency room conducted by emergency medical service ambulance. At that time was the firefighters after approximately 20 minutes of trauma. And he had a stab wound in the Intl zone, okay? The firefighters just get the patient at the scene and take to us in our hospital. And they make no one procedure during the transportation, okay? At the emergency room, he had a peripheral airway, cervical region unchanged, reduced murmur in left hemothorax, penetrate wound of approximately 2 centimeters in second space intercostal, and in the hemiclavian line with blood donation from the wound. At this moment, the patient didn't have escape of air. He had respiratory rate 27, saturation of oxygen 89% with oxygen per mask. He has a regular heart rate, abdomen flaccid, painless on palpation, and without trauma stigma, base unchanged, and he has a very good and most skin. A blood pressure is worth 58 per 34 million years. For mercury, he has very hypotension and cardiac rate 88 beats per minute. Glasgow 13 is occurring and photoregent pupil, movements present upper and lower limb, and he has absence of fracture and another alteration in the limbs, upper and lower limbs. Okay, and I am asking you what we're going to do now.
Go to Sao Paulo, Dr. Calais.
Yes. In these situations, if you have, it's very important in these situations to have murmur in to see the murmur on the left chest, and the patient may be penetrates injuries in zone 1. So, yes, murmur in left side. Okay, you can go to, in these situations, you go to put a chest tube because they may probably have a hemothorax or hemothorax. So can explain sometimes in these situations the hypertensive pneumothorax. So in this situation, and I put these patients make a fast exam to see the pericardial window. If you have blood in the pericardium, go to the OR. That's it.
All right, thank you, Dr. Calais. Atlanta, Dr. Frisbee.
Well, that's probably what I would do. I'd get the lines in him, put two chest tubes in, and start pouring blood into him. See if you can get that pressure up. And I would also do the pericardial fast and see what we're dealing with here. But that's the first things I would do.
Thank you, Dr. Frisbee. Let's go Mexico, Dr. Ruiz Pierre.
Yeah, first we have to drain the air or blood from both the hemothorax, and then we check if the pericardial is the side of leakage. And if this, we can proceed there if we have the option of operating room in the emergency room, or well, try to make time to get to official OR operating room.
Thank you, sir. Boston, Dr. Oyman, your comments, please.
Well, you have a patient with a stab wound in the left chest who is hypotensive. So why is hypotensive? Can he have a tension pneumo? Is he bleeding in the chest? He has a pericardia tamponade, is breathing from the heart into the chest. So this patient with this blood pressure, you don't have too much time. So if I don't even know if I would have time to get the chest X-ray. So let's start one by one. Tension pneumothorax. Tension pneumothorax, I know this is not the book, but in my experience, the easiest way to diagnose a tension pneumothorax is to feel for the trachea. Every single tension pneumothorax that I see, except once I saw one that was loculated that didn't have this, the trachea is deviated. The trachea is palpable over the clavicle. So you have the diagnosis, you need to decompress the chest. If it's not, most likely than not, this is bleeding or a pericardia tamponade. The ultrasound, we can get an ultrasound to make these two diagnoses very quickly. So we can look at the pericardium, and we can also look for pleural sliding, which most likely would not be present. But if it's not tension, I wouldn't be too worried. And after that, what to do with this patient? This patient needs to be in the operating room. I wouldn't even waste time putting a chest tube in the trauma bay if I can make it to the operating room. Sometimes this is experience, you know that if you will make it or not, and you might need to open the chest or put chest tubes there. But ideally, you want to do this in the operating room. Pericardia tamponade has been classically described 3 stages. This is between 2 and 3, or almost 3. The treatment for this is surgical decompression. So I wouldn't even try to intubate this patient. If I go to the operating room, I will prep the patient. I will make sure that both arms are tucked on the sides. And I will prep the patient before they do the induction. Even using a Tomidate, that's enough to take a little bit of the remaining sympathetic discharge away to cause an immediate cardiac arrest. And I will be, like Dr. Frisby would say, and I will give volume. The way to overcome a pericardial tamponade is to increase the pressure in the right side of the heart, and that buys you time. However, if he's bleeding, that will be negative, because it has been shown that patients with penetrating torso trauma who are bleeding, they should be kept kind of hypotensive until the control can be obtained in the operating room. So essentially that, I will rule out the tension pneumo by palpating the trachea. I will do a quick ultrasound. Based on that, I will decide to go to the OR or do something else in the trauma bay. And this patient needs to go straight to the operating room. Thank you.
Thank you, Dr. Oyman. Let's go to Sarasota, Dr. Untrak.
Yeah, so I agree with all the other comments. Interesting, blood pressure is 60/30, but he's not tachycardic. The pulse is 88 to 90, and he's awake. So, you know, and he needs obviously to be in the operating room based on where the location of the stab wound. The only thing I might consider is the ultrasound is right there. Look at the pericardium and look at the left chest to see if there is a large pneumothorax, and to sort of compromise on the way to the operating room. If there is a tension pneumothorax, I would at least try to decompress it to buy a little time, so you make it to the operating room rather than spending a few minutes to put the chest tube. And also with the heart, if there's a pericardial tamponade, then I would go ahead and aspirate quickly, and then proceed straight to the operating room for a left thoracotomy.
Thank you very much, Dr. Untrak. Dr. Supa in Bangkok, your comments, please.
I agree with all previous comments, plus applying pressure to the bleeding wound. And sometimes if we think that this is subclavian artery bleeding, putting in a Foley catheter and blowing a balloon may help tamponade the bleeding vessel. But I agree with our previous comments, and we should rush this patient to the operating room. Thank you.
Thank you, Dr. Super. Campaigners, Dr. Fraga, your comments, please.
I agree with the previous suggestions. I think you cannot lose time at emergency department with these patients. Probably put the chest tube on the left because the patient can have massive hemothorax. And the ultrasound is very important to decide what to do with the patient. Because if you have a cardiac tamponade, you need to go immediately to the OR, and this is a surgical patient. And if you have time, you have the chest ray available at emergency department, you can do the chest X-ray. But if not, I think the ultrasound, you can decide the best treatment for the patient.
Thank you, Dr. Fraga. Dr. De Moya, your comments, sir?
Sure. So I would, most likely we would just put a chest tube in on this left side, make sure that it's not a tension pneumothorax. At the same time, we would ultrasound the heart, take a look and see if there's a pericardial collection of fluid, and then gain access and start blood transfusion right away. We would then see how the patient responds to the chest tube, and then if no response, or if we see a positive fast exam with a pericardial potential tamponade, then we're just going to go straight to the operating room.
Thank you, Dr. De Moya. Dr. Ricard, your comments, ma'am. You're muted, Dr. Ricard.
Hi there, can you hear me?
Yes, ma'am, loud and clear.
Sorry about that.
No problem.
I agree with what everyone was saying. I think we would start out with a cardiac fast, place a chest tube on the left side to rule out tension pneumothorax, and proceed directly to the OR.
Very good. Thank you, ma'am. Any additional comments before we return to Dr. Wellington?
Okay.
So,
I'm sorry, Dr. Wellington, 1 second. I think Dr. Hoyman has something for you, for the group. Go ahead, Dr. Hoyman.
Okay.
You're muted, Dr. Hoyman.
Are you continuous right now? Okay.
Yeah, just hold on 1 second, Dr. Wellington. Go ahead, Dr. Hoyman.
Go ahead. Go ahead.
Okay.
Okay.
All right.
I continue right now. I think it's better.
Thank you.
The intervention that I make at the emergency department, we administrate 500 milliliters of ring lactate solution, and the patient has no response. Okay, and another 100 milliliters was to be administered. We administrate patients at next haste, 1 gram, because our protocol. Okay, and we order 2 units of red blood cell concentrate negative and 2 units of a fresh frozen plasma, because patient has a shock grade 3 to grade 4, and I think necessary at that time. And we get a blood sample taken, we make a blood typing, and we make at that time arterial blood gas analysis that show that patient has a metabolic case and basic excess -12, lactate 7.4. and carbonate is 16. Okay, that show that patient has a tissue hyperperfusion, probably that he has a bleeding, and we need to find this bleed. Okay, at this time we planned to make put a chest tube in this patient. Okay, and we performed ultrasound. Okay, that showing this volume was to moderated hemopericardium. Okay, but patient we give another 500 milliliters of a solution of a lactate ringer, and he has no response. Okay, but to have the diagnostic of a voluminous hemopericardium. What to do now?
Dr. Untrack, your comments, please.
Yeah, so obviously he's in shock. He's not doing well, and he's holding on. But I would in that case, and I don't know if you looked at the chest, but I think he's basically his cardiac tamponade. I would very quickly, without wasting time, it's huge. I would do a subxiphoid. I would just do a pericardiocentesis right there, and then just to buy a little time, right to the operating room and do a median sternotomy. I would go right to that because of where the stab wound is. But I wouldn't really waste any more time with this.
Thank you, Dr. Untrat. Campaigners, Dr. Fraga, your comment, sir.
Yes, take the patient to the OR. If the patient, the blood pressure is around 50, the systolic blood pressures, I think you can try to perform a sternotomy, because if not, if you don't have the equipment available to open the sternum, maybe an anterolateral thoracotomy on the left. But it's a surgical case, you need to go straight to the operating room.
Thank you, Dr. Fraga. Bangkok, Dr. Supa.
At this point, I think we should perform resuscitative thoracotomy, left anterolateral thoracotomy, and try to release the tamponade quickly and try to get a quick suture to control the bleeding wound from the heart, and then take him to the OR. Thank you.
Thank you, Dr. Supa. Dr. De Moya?
So if the patient is mentating, then I wouldn't do the thoracotomy. If he was mentating, then I would take him right to the operating room and just do a median sternotomy. I think the only thing I disagreed with the other group was just a comment about the pericardiocentesis. I don't think that there's any role for pericardiocentesis in this scenario. I think that's a waste of time, and you're just going to be sucking on clot, and it's not really going to be, it's not going to have any real effect. So I would throw that out. But otherwise, I would agree with everybody and just go ahead, go to the operating room and do a median sternotomy in this case. If the guy is now not awake and he's completely crashing on you, then yes, I agree to do an ED thoracotomy, to do a resuscitative thoracotomy, open up that left chest.
Thank you, Dr. De Moya. Dr. Ruiz-Pierre, your comment, sir.
Thanks. I agree. We'll make a median sternotomy only if I can get an operating room in this moment and the patient not responding. I will do a left thoracotomy, fifth space, sorry.
Thank you, sir. Sao Paulo, Dr. Calais.
Yes, may I comment something? I think it's very important in this case. You can see something important. You have in the trauma, in penetration trauma, you can have injuries of isolate injuries of the cardiac. You have a tamponade is the surrounds of the shock. Sometimes if you the reposition of the blood too much and fluids too much, when the situations, you can aggravate the patient, because the patients cannot the cardiac movements cannot to adequate to control the fluids in these situations. The hemodynamic may be not be increased, different than when you have a hemorrhage as surrounds. Here you have two, and the tamponade, the hemorrhage is usually controlled by the tamponade. So there's a constriction of the cardiac. In these situations, you can quickly go to the OR, and the reposition can start during the surgery, when you can see, control the hole in the heart or in the vessels, can see in this position, because you can remember that is a position you can have usually of the base vessels of the heart, because it's the second intercostal space. So in this situation, you can start here in Brazil. We usually go to left anterothoracotomy and sometimes a shell clamp incision 1 to 2, or can, if you have results, you can go to a sternotomy, maybe more appropriate incision in these situations if the patient is stable. But sometimes here in Brazil, I don't have equipments to do sternotomy in some hospitals. So this much more easy to make anterolateral thoracotomy. But it's very important because if you continue to replace volume in these patients in this situation, you can aggravate the tamponade and the patient can have a cardiac arrest in the emergency room.
Thank you very much, Dr. Calais. Dr. Hoyman, your comments, please.
Well, this patient has pericardia tamponade. I disagree. This is probably the first time ever that I disagree with Dr. Collet. This patient needs volume, and with some caveats here. First of all, we know that penetrating torso injuries, that the resuscitation is delayed until they are in the operating room where the control of the bleeding can be achieved, do better. However, for this patient, the only way that this can happen is if we can increase the filling pressures of the right ventricle that is collapsing because of the pericardial fluid. So I will be, I will go, if I can, I will go immediately, as I said before, to the operating room and prep the patient while it's getting fluids. And after that, when they induce, be able to be ready to, with the skin incision immediately, because this patient is going to arrest the moment that they do the induction. My preferred approach for the case like this is a median sternotomy. For many reasons, it's better tolerated, it gives me very good exposure. I can solve essentially almost everything, particularly if the injury involves the pulmonary hilum. The anterolateral thoracotomy, the left anterolateral thoracotomy, maybe there are better surgeons in this room, but for me, has given me very, very limited exposure. I know some people say that you can repair like 95% of the heart injuries through an anterolateral thoracotomy. I think those surgeons are either extraordinary or they are just talking, we haven't done this. I know at least one case of that's the case, but I always end up doing a clamshell incision, always. I don't have a single case where I didn't end up doing a clamshell incision, which give you a terrific exposure, but it's extremely morbid postoperative for the patient. So if I can, I will go to the operating room, prep the patient, do the induction and do a median sternotomy. If I cannot, I will do an anterolateral thoracotomy that most likely than not, I will extend to the other side of the chest to get good control because I cannot really get anything done through a small anterolateral thoracotomy. To cut the sternum, we have the Lischke knife now in the trauma bay. In the past, I used Mayo scissors, even in young patients. Usually you can divide the inferior sternum and extend the incision to the other side. In the books, they say that you need to control the internal mammary. In these patients are in cardiac arrest, you don't need to worry about the internal mammaries. You worry about the internal mammaries after you resuscitated the patient and you get the bleeding and you are very happy to have to deal with internal mammaries that were transected. But this patient needs a surgical decompression. Needle decompression would not work. This is majority of the time when you open the pericardium, it's full of clot. So needle decompression doesn't work in cases like this. It's surgical decompression in this case. You don't have any other option. Thank you.
Thank you, Dr. Hoyman. Dr. Frisbee, your comments, sir.
Well, Hoyman's right. You know, what you're looking at on the screen is probably clot. The times that I've had to do this in the emergency room, I just evacuated the clot. But don't worry so much about how to get the chest open. Remember the old saying, there's no chest that can't be opened without a strong right arm and a Lepsky knife. So just, it'll zip right open for you. But he needs to have an operation for sure. That's all I've got.
Thank you very much, Dr. Frisbee. Any additional comments before we return to Dr. Wellington? Okay, back to you, Dr. Wellington.
Okay, let's continue. After this, the patients, we are preparing to put a chest tube, okay? But patients take an responsive impulse loss and we made the diagnosis with a traumatic cardiac arrest, okay? At the moment, we perform like a trauma team. We always have 3 doctors to when the patient arrive to our emergency room. We have our a team leader and another 2 doctors. Dr. 1 always take care of the airways, and Dr. 2 check the chest, the abdomen, basin, and limbs. And if this patient is necessary to make a procedure, they are all capacity because all of them are trauma surgeon. Okay, at this patient, Dr. 1 made the thoracotomy intubation, and Dr. 2 made the left anterolateral thoracotomy, and this procedure was made both at the same time. Okay, and we have a video of thoracotomy. When we opened the pericardium sac, there was release of amount of clots. There was many clots, and the patient has a big clot in the chest. Okay, we found approximately 1 centimeter wound in the left ventricular posterior wall with an active bleeding, and IEM make a U-point myocardiogram. I think this point is more hemostatic, and this give less ischemia to the myocardial. Okay, and after when I finish this point, the patient persists with bleeding on the site, on the wood site. It was very, very difficult to access. In the emergency room, we find this, okay? And at this time, we tamponate with compress. We put 5 compress in the chest and take this patient to operating room. After, when you open the pericardium sac, the patients turn more stable, and we take him to operation room where you made the clamshell incision. When we arrive at the operation room, we try to identify the bleeding, but the incision is too small to access, okay? And we find the intercostal artery injury and make coagulation. This is the video that we can make to have residents of trauma, and I showed them the anatomy of the heart, okay? And this is a video. We're going to show the wound at the left posterior ventricle. Right now, you're going to see the suture in here in the left ventricle. Okay, and we make the ligation of the mammaria. Okay, we make a bilateral thoracostomy, and we close the chest, and we send this patient to the unit care. Okay, and this is what we made to him. We make this incision because it was very, very difficult to access the bleeding. And the bleeding, it was in the approximately second space in the left. It was very difficult, okay? After, when we have a critical case, when you made some procedure in our emergency room, we always take a discuss with this procedure with our team, okay? At the time we have here Dr. Rosana Galete, Dr. Leonard, both are trauma surgeons that can participate. We have here nurse, we have here physiotherapists, we have here our trauma resident, and this is the moment when we can evaluate improvements to trauma team, okay? It's the moment where we can learn with each other what we need to make best in the next case if it happens. And it's very important to us, okay? And I always say that no one works alone, okay? And this is the time that you come in every person that can participate and say thank you. You are very important for our team, okay? After this, the patients come to unity care, where we begin the antibiotic, ampicillin plus bactam. This is our protocol when it has a potential contaminated surgery. We begin enoxaparin 40 milligram once a day to prevention of thrombo, prevention thrombosis. And we made a transthoracotomy echocardiogram in the 4th day that showed normals, and in the 5th day, patient was intubated, okay? But this patient, he doesn't go on very good, okay? He begins with a lower limb edema. He has signs of a heart failure. In the 3rd days, he evaluates with a dyspnea and drop in saturation. And I ask you, in your experience, what happened with this patient right now, okay?
Thank you, sir. Dr. Frisbee, your comments, please.
He needs an echo. That's what I would do.
Okay.
What?
An echo.
I echo. Okay. You are making another echo. Okay, great.
Thank you, Dr. Frisbee. Mexico, Dr. Ruiz.
I agree this need a echocardiogram or angiotomography to, or D-dimer measure to rule out thromboembolism.
Thank you, sir.
Boston.
Thank you, sir. Boston, Dr. Oyman.
So this patient is coming 13 days later with sign of heart failure. Why he has heart failure now? He had a normal echocardiogram and post-op day 4, I think. So the most likely cause now is reaccumulation of pericardial fluid. Less likely causes will be a miss, papillary muscle injury during the stab wound, but that should have been seen probably during the echo and post-op day 4, but that can result in heart failure. Usually it's more acute, but maybe that's what's happening. Maybe the patient has also a ventricular septal defect that was caused by the initial stab wound, but they should have seen that in the echo. He will be hypercoagulable after the trauma, so a pulmonary embolus is a possibility. However, less likely because patients who have pulmonary embolus that give them all the symptoms are really very hemodynamically unstable. So my bet is this is reaccumulation of pericardial fluid. I wouldn't be surprised if this patient has big heart on the chest X-ray, and the treatment for this, yes, usually will be pericardiocentesis.
Thank you, Dr. Hoyman. Dr. DeMoya, your comments, sir.
So I think the top 3 diagnoses in my head would be pericarditis, reaccumulation of fluid, and PE. And I think that these are things that need to be ruled out at this point with probably a combination of probably I would start off with an echo, as Dr. Frisbee said, and then I would go ahead, and that would give me a little bit of better idea of what is actually failing. Is it the right heart, the left heart? Is it look more like a pericarditis picture? And then I would go on to rule out a PE, probably with a CT angio, pulmonary angiogram to make sure that there's no large PE, and then go from there. And certainly the ultrasound is going to tell you whether or not there's a reaccumulation of fluid there as well. So those are my kind of top choices. I think that the pericarditis is a well-described phenomenon after cardiac surgery, and referred to as Dressler syndrome, and it's one thing that I think we see oftentimes happen in a delayed fashion after the initial repair.
Thank you, Dr. DeMoya. Campinas, Dr. Fraga, your comments, please.
I agree to investigate pericarditis or PE. I think the CT, the angio CT, is very important for this patient at this moment. And before this, congratulations to save this patient. Congratulations because the team work was very important to save this patient, very critical patient, and with the resuscitative thoracotomy at the emergency department, very, very well done. Congratulations.
Thank you, Dr. Fraga. Sarasota, Dr. Untract, your comments, please.
Yes, well, I think those previous comments are very thorough, and I don't have much to add. I suppose the transesophageal echo would have ruled out an internal cardiac injury, a VSD or something like that. I'm not sure, but the other comments I think were quite thorough. I wouldn't add anything more to those.
Thank you, sir. Sao Paulo, Dr. Collet.
I think there's nothing to add because a pericardic make internal cardiac injuries and make thromboembolism, make the case of this complication. So I agree with all the comments that go to angio CT, and maybe this patient is important to make an echocardiogram and esophageal echocardiogram too. Thank you.
Thank you, Dr. Collet. Bangkok, Dr. Superek.
I agree with the previous comments to get echo and all the differential diagnosis for this patient. Thank you.
Thank you. Dr. Villaquarian, have you seen enough to comment, or would you like to continue to observe?
Thank you very much. I'll continue to observe because I missed half of the presentation. Thank you.
Yes, sir. Thank you. Any other comments before we return to Dr. Wellington? Back to you, Dr. Wellington.
Okay. We perform a CT angiography that show that patient has a pleural infusion that at this time the patient there is no one tube no more, and it's necessary to make another thoracotomy that can drainage 700 milliliters of a serum-matic, but the patient has a emboli in the pulmonary artery that make the diagnosis of a pulmonary thromboembolism. We performed a transthoracic echogram because at the time the patient we don't have a esophagus, okay, and he has signs of enlargement of the right heart chambers with this vein septum to the left. He had moderate acoustic insufficiency and accentuated pulmonary hypertension, and making a traumatic pulmonary due the pulmonary thromboembolism. At the time, we asked to the vascular team, to our vascular surgeon, to them if necessary to make a procedure, and they just indicate a full anticoagulation with enoxaparin 1 milligram by kilogram twice a day. Okay, the patient had a good evaluation. He goes outside to the unit care in the 5th day. He stayed with us in approximately 35 days, and he received the varfarine once a day per 2 months, and now he's follow up with travel surgery and pneumologist. He come back with us in last month, and he was very good, and he turned to his activity. Okay. This is what I want to say to you. I said thank you, gracias, obrigado for everyone here. Okay, this is the case. And you want to make any comments now? Thank you.
Thank you, Dr. Wellington. We'll go around for Dr. Wellington. We'll go around for final comments. Okay.
Okay.
All right. Very good. Go ahead, please.
I am very happy to be here. Okay, it was a pleasure to present in this Tele-Grand ground. I think it's an opportunity to show our service in Brazil. We are a service that we have many part of our surgeons are trauma surgeons, and we are performing the best for our patients. And that image that can show our trauma team when we make the briefing, I think it's necessary to make this, okay? When you have a critical procedure in your hospital, I can indicate to do that, okay? Thank you a lot. I'm very happy to be here. I'm very happy to the opportunity. Okay, thank you.
Yes, sir. Thank you. Dr. De Moya, your final comments, please.
Great save, guys. I think it was a great case. You know, these are always tough cases. Certainly, if you're going to be able to save somebody with an ED thoracotomy, this is going to be the patient with a single chamber injury who's, you know, comes to you awake and you get them to the operating room real quick, but still takes a great team to work together to have a save like this. So great job. My only kind of final comments, I I like to always review the approach to doing a thoracotomy, which I think is important for people. One of what I teach folks here is that when we do the anterior thoracotomy, anterolateral thoracotomy, as was mentioned actually by Dr. Ojman, that if you get in and you have a cardiac injury, I always convert to a clamshell because you need that exposure. So have a low threshold for doing that clamshell when you enter the pericardium and it's positive. But the first thing that I do when I go into an ED thoracotomy is I push the pericardium down, and I push the pericardium down to enter the right side of the chest. So I routinely enter the right side of the chest from the left side, and that basically, in essence, makes the right chest tube that people are trying to put in on the right side moot. You really don't need that, and you don't have to rely on that right-sided chest tube that now that might be kinked or might be in the subcu space or something like that. So you're in the chest, just get into the right side of the chest real quick and easy, and rule out that there's blood, any blood on the right side. If there's blood on the right side or if there's blood in the pericardium, then I immediately convert to a clamshell thoracotomy. It just gives you a lot better visualization and to save the patient. And then when you go to the operating room, if you're not doing a resuscitative thoracotomy, but you're going straight to the operating room, I think the point that was brought up earlier is that once they get induced, they crash. So it's really important for people to have them widely prepped out and ready to go, prepped out before they get induced, if possible. And then you're ready to go immediately with the sternal saw or with the bilateral anterior lateral thoracotomies if you need to. But great case. Thank you for the opportunity to participate.
Thank you for your comments, Dr.
Gary,
go ahead, please.
Dr. Fraga, I have one question. You were discussing here with the residents and the students. Nobody comments about the pericardiocentesis. Do you think is a role for pericardiocentesis in hospital or sometimes in pre-hospital when you don't have the definitive diagnosis of the pericardial injury, cardiac tamponade? What's your opinion of our colleagues?
Can I answer this question?
Yes, sir,
I think
please.
pericardiocentesis is not good to this situation. When you have a chronic tamponade, I think it's more is because we has a fluid, okay? When it has an acute tamponade, we have many clots, and at this time, I think it's not very good to you make this procedure. And I think if you are in a hospital and you has a capacity to make a thoracotomy, I think it's the best procedure at this time. Okay, this is what I think about pericardiocentesis.
Thank you, sir. Any other comments? Reply to Dr. Fraga? Okay. So we'll proceed with our final comments on Dr. Wellington's case. Dr. Untrack, your final comments, please.
Yes, well, great save. Just one brief question. So what was the time interval between when the patient arrived in the emergency room and then the cardiac arrest?
Okay, I think it was 9 to 10 minutes. It was very fast. We proceeded the ultrasound after the patient evaluation to cardiac arrest. I think it's maximum 10 minutes. It was very fast. I think the time was big, seeing the patient has a cardiac tamponade, but we try to take this patient to the operating room. In that time, we have our operating room in the second floor. Then I can say to our residents, when you always has a patient that has a hypotension like this, okay, the patient he was lost the physiological response for the trauma. He has no more tachycardia. I think this patient has a imminent cardiac arrest. and I think it was 9 to 10 minutes. Okay, is this?
Yes, well done.
Thank you, sir. And may go, Dr. Rui.
Well, I want to congratulate Dr. Wellington for his team for this case, and the SPT for this opportunity to participate on this case. Thank you. Good day.
Thank you very much, sir. Boston, Dr. Hoyman, your final comments, please.
Well, I think that this patient was very lucky to have you as a surgeon because you did everything very, very well, and he's alive. And I want to congratulate you and thank you for presenting this case. Otherwise, in terms of comments about the case, I think Dr. De Moya has been reading my mind. I should probably be wearing my Team 4 helmet because I was going to say exactly what he said. Thank you.
Thank you very much,
comments.
Dr. Hoyman. Atlanta, Dr. Frisbee, your final comments, sir.
Good case, nicely done. The only criticism I would have is, we get very, very complacent in the United States concerning massive transfusion protocol in the emergency. We can call for it in the ER. Some places just aren't equipped for it. And you did a very good job despite not having that. Very, very good case. Congratulations.
Thank you, Dr. Frisbee. Bangkok, Dr. Supa.
Thank you, Dr. Wellington, for presenting this wonderful case and great save. And I learned a lot, as usual, from this conference. Thank you, everybody.
Thank you, Dr. Supa. Campinas, Dr. Fraga, your final comment, sir?
Oh, just congratulate Dr. Wellington to present this case, and congratulations for your team. Dr. Rodrigo Caselli is the chief, the coordinator of the Hospital de Base, Brasilia. Brasilia is the capital of Brazil. I think it's the first time they present a case in the Panamerican Trauma Society Grand Round. So very welcome, good case. And probably Dr. Martos will say some words about the how it's very, very important for the residents to join a conference like this one. We have new residents starting today, the program, and I hope every Friday, every month, learn with my colleagues from different countries in the world who has a large experience to take care of trauma patients. Congratulations, Dr. Wellington.
Dr. Caselli, would you like to make some final comments, sir?
Yes, thank you. I want to know, I want the experience of the colleagues about this patient has a thromboembolism, okay? Despite he was using enoxaparin 40 milligrams per day. Do you have any experience with the incidence of thromboembolism in this kind of case? Do you think there's any relationship between the thromboembolism and the incision, clamshell or lateral anterolateral thoracotomy? I want to know from the colleagues, because the patient was using enoxaparin 4 milligrams per day, and despite this, he made a thromboembolism, a bigger thromboembolism.
Any comments from anyone?
I would say that, depending upon the size of the patient, you may have been, there may be underdosing too that's going on. So activated factor 10 levels is, I think, important to understand to gain a better sense of whether or not they're actually being dosed properly. When we reviewed our dosing, now here in Wisconsin, certainly I don't know how it is there in Brazil, but our body habits tend to be a little bit on the larger side. And we had about 30% of our patients were being underdosed with the generally accepted dosing regimen. So we've changed it, and now we follow up all of our patients, particularly those that have a higher BMI, with levels to actually see whether or not they're anticoagulated as much as we think they are. So that's my only other thought with this. I think that the patients with a cardiac injury certainly are at a higher risk of being in a hypercoagulable state from the endothelial damage, but otherwise this was on the left. The injury was on the left side. This was the pulmonary embolism, of course, was on the right side. So it wasn't directly related to the cardiac injury, though.
Thank you, Dr. De Moya. In a moment, we're going to go to Dr. Calais for his final comments on the case, as well as to close our session. But before we go to Dr. Calais, are there any other final comments? Okay, Dr. Calais, your final comments and to close out the session, please.
Yes, I want to make the comments. This case, very important case to discussion. Cardiac injuries, penetrating cardiac injuries can be more not too common as in the past in our trauma hospitals. So it's very important to know how to manage this patient. All the comments is very important for this case, and I believe it's a very interesting case. Very, very interesting. Congratulations, Dr. Wellington, Dr. Caselli, for the presentation. It's a very important case. There's no more comments. I believe it's very important. And remember, in fact, important is trauma patients may be thromboembolism, maybe prophylaxis in these trauma patients. Any patients is very important to do and try to make it early in the trauma management. Thank you for the presentations. I invite all people to come our next presentation next week. It will be at 12 p.m. in the 12 a.m. in the Miami time and 2 p.m. in South America, in Brazil, sometime in the case, and invite all people to participate. It's very important for the students. You can see the students can see the conference during the conference and can see in the YouTube. You can see YouTube, Panamerican Trauma in YouTube. You can see all the conferences in the Panamerican, and you can see when you have time, you can see and review the conference. It's very important to see this. Thank you for the presentations. I continue to invite all people in the Pan-American Trauma, in the SBITE, and the Brazilian Congress, and the other societies can participate and share the case in this Tele-Grand house here. Thank you very much for participation, and till next week.
Thank you very much. Thanks again, Dr. Wellington, for presenting your case. Thanks to everyone. Dr. Martos.
Gary, again.
Yes, sir.
Thank you, Wellington. Great case. It's nice to see SBITE, Distrito Federal participating. Congratulations. Colette, thank you for leading the telemedicine share for Panamerican Society. Just remember, next week we're gonna have another good case. There's a couple of you guys, please talk to Valeria to schedule your presentations. And also remember, this Wednesday, 6 p.m. Miami time, we're gonna have the meeting in Spanish. Another good case presentation. Gonna be and then Dr. Fraga gonna be the former president of the Panamerican Society, gonna be interviewed after this meeting this Wednesday on the 3rd at 6 p.m. Miami time. Okay, and I stimulate all you also to this registration for submission for papers for the Panamerican Society and SBITE Congress are already open. So I would like you guys to take a look and simulate everybody to send papers for the meeting going to be in October in São Paulo, Brazil. Thank you all.